Dr. Larry brings you another segment of Did You Know?
We've all heard somebody say, I've got a bad knee or hip, or maybe we say it about ourselves. In addition, commonly in healthcare, there's a lot of chit-chat about that. We ache as we age, and then our joints begin to rage. And eventually, at some point, many of us will have to address some type of bone or joint issue, and you might be hurting so bad, you need a Kleenex or tissue. Or maybe you're the weekend warrior or athletic type, and after many years, you know that noise or pain in your hip or knee just ain't right. So where do you go for a joint that is screaming no? Well, it's a field of choices out there, but when it comes to choosing an organization of surgeons for something as important as an artificial replacement, you want to pick a facility that has its processes and people operating like a well-oiled machine. Because it's the style of this next organization, OSMS, that separates them from the rest. They are doctors who not only own their clinic, but actually focus on the patient. So pay close attention to our next guest. He's a practicing physician, board certified in a specialized field of bone and joint care. And catch this, he specializes in revisions and infections of prosthetic joints, which will be the main focus of our show today. So for the sake of simplicity, we're going to call this segment Ask OSMS. Dr. Roedel, welcome to the show.
Hi, Dr. Larry. Thanks for having me.
Yeah, absolutely. When I had spoken to some of the other practitioners at OSMS, I was equally as excited to have you come on here because I think for the topic we're going to dive into today, there's an overwhelming and underwhelming sensitivity to the issue when it comes to prosthetic implants, joint replacements, and of course you do that as well too. But you have a separate specialty that we're going to dive into, and for those of you out there that are listening right now, if you've had an infection in a joint replacement, right now if you're having an issue with that, then this is going to be the show for you. You're going to want to listen to our physician today, and Dr. Roedel. But first, I always like to get the basics out of the way. Give us your full name, your license type, and board certifications.
Yeah. So my name is Gordon Roedel. I have an MD degree from the University of Wisconsin. I did my orthopedic residency training in Omaha, Nebraska, as well as an adult reconstruction fellowship in Morgantown, West Virginia. And currently, I'm in the process of getting my board certification through the American Board of Orthopedic Surgeons.
Excellent. And then, give us a brief history. I find this kind of interesting question to ask, why people choose, of course, career paths to choose. But, when you can work at different facilities, hospitals, et cetera, why did you choose to practice at OSMS? What stood out to you?
Sure, that's a great question. So my wife and I are both originally from Wisconsin, and despite being out of the state for our training, we knew that we wanted to come back to the area. And so I'd interviewed with several practices, some hospitals throughout the state, but I was really attracted to the culture and the vision at OSMS. And that really guides everything that we do here. As a private practice, we have the independence to be able to make decisions that are in the best interest of our patients. And as the group has continued to grow, we now offer a wide spectrum of orthopedic and sports medicine care, and that was really important to me.
Yeah, that autonomy, and like you said, the culture as well too. I've been a referral source for OSMS for quite some time, and now opening up the interviews and having some of the various physicians come on the show. That's one of the things too. And I made a site visit there recently as well. Just happened to be out of the office for a day and was down the area with my wife. And same thing, it just kind of matches front end to back end. And the feedback from the patients there when they go down to OSMS is the same. It's so Dr. Larry, that place really has it together. So made perfect sense what you're saying and why you chose it. Now, that's about why you chose OSMS. However, we all like to know a couple little personal fun tidbits or things or talents or hobbies that you might have. Of course, I don't want to be a spoiler here. I read that you grew up on a farm, but do you have like one unique personal talent or hobby or interest that you have that you'd like to share with us?
Yeah. So I actually grew up on a lot of farms. I grew up in Loewen, Wisconsin, which is a small dairy farming community in Clark County. My dad was a dairy veterinarian, and so going around with him to the different farms, I actually I spent time on a lot of different farms growing up. In terms of like a unique talent or hobby, that's something that actually, the one I'll share here is one that started when I was in my undergrad. I ended up taking a microbiology class, and part of our laboratory experience there was to work with a certain yeast species, and we actually did some beer brewing, and I really got into that sort of thing. And I actually do small batch craft beer that I brewed myself. So I just finished up about a month ago. I finished up an Oktoberfest that turned out really well. It's a fun hobby for me to be able to do and share with family and friends.
You just jaw dropped and made me jealous. My wife and I were just talking about that. She's like, babe, why don't we do it? We like little craft beers and things like that. And I like going to like Woodman's down in that area and even up around here and like finding the little niche sort of craft stuff. And so I was wondering where I was listening to you said microbiology is like, okay, so he's got something kind of science going on. You got your own little craft microbrewery for friends and family. It's perfect.
Yeah. It's a great hobby. I'd recommend it.
Yeah.
It's a worthwhile venture.
Do you like stouts, porters more, or are you more lean more towards like an IPA or a lighter lager or something?
I tend to go towards the IPAs. That kind of has been my home base that I've always come back to.
Okay. And I got to circle back around and ask you a question. So you didn't quite follow in Dad's footsteps. You decided to branch off and go into orthopedic surgery. Did he scratch his head and be like, how come you don't want to be a veterinary doctor like myself? Was there ever a question about that?
No, he was pretty gracious about it. He understood it was my own journey and I needed to do what made sense for me. But he has managed to mention a few times that real doctors treat more than one species.
That's great. My dad's a dentist, and so his friends would be like, so is your son Larry? This is when I was younger too. Is he going to take over the dental practice? He's like, no, Larry's shown no interest in dentistry whatsoever. And so I said, hey, but Dad, I'm still working with my hands, right? And using the brain. He's like, right. So like I said, he it's great. Dad's got a good sense of humor. Okay, what I would love to jump into, and I think as far as kind of the public goes, and as far as just we all come from these different walks of life. Physicians have this thing called fellowship training. They have your board certifications, your fellowships, and I'd like you to generally explain what fellowship training is to the average listener. They're going to go on, they're going to look at your profile, they're going to see stuff, they're going to see this fellowship, board cert, but just kind of give us the 8 to 10 year old kid explanation of what a fellowship training is for the average person. We're talking total failed hip knee replacements, the revisions and infections in those replacements. His focus via education and training comes up just after the break. Stay tuned. You're listening to the Dr. Larry Radio Show. We'll be right back.
Dr. Larry will be back in a moment. Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. If you're just tuning in, perfect timing. I'm interviewing Dr. Gordon Roedel, orthopedic surgeon from OSMS. That's Orthopedic and Sports Medicine Specialists clinic from Green Bay, and they have other multiple locations as well. Our focus of the interview is on the revisions of hip and knee replacements due to failures, why they occur, and what to look out for. Also, infections of those prosthetics as well. However, for the next segment, I wanted to lay the foundation of Dr. Roedel's medical training via his fellowship in this subspecialty. Keep in mind, he chose this based on a desire to help patients who may encounter these problems. Let's listen in. Roll tape. What I would love to jump into, and I think as far as kind of the public goes, and as far as just we all come from these different walks of life. Physicians have this thing called fellowship training. They have your board certifications, your fellowships, And I'd like you to generally explain what fellowship training is to the average listener. You know, they're going to go on, they're going to look at your profile, they're going to see stuff, they're going to see this fellowship, board cert, but just kind of give us the 8 to 10-year-old, kid explanation of what a fellowship training is for the average person.
Yeah, absolutely. So after completing medical school, all orthopedic surgeons complete a 5-year training program that really covers the breadth of all orthopedic care. And that is called a residency. So you may see on our profiles that there's an explanation of where we did our residency. And that's what that's referring to. A fellowship is then an optional additional year of training that can be pursued following the residency. And that allows a surgeon to gain further experience with technical skills or a particular subset of orthopedic surgery. And some examples of that might be hand or upper extremity surgery, spine surgery, or in my case, adult reconstruction, which typically is going to focus on surgical replacement of arthritic hips and knees with metal and plastic components.
And as far as is it required, encouraged to go off into these 1-year specialty programs, or can you pretty much stop after the 5-year and go out and do what you need to or want to as far as orthopedic surgeon goes?
Yep, it's completely optional. So not a requirement at all. And we do have several orthopedic surgeons here at OSMS who did their orthopedic residency and knew that they wanted to practice general orthopedics, not really focus on one specific area, but be able to treat a breadth of orthopedics. And so they went straight into practice. This appeals, I think, more to individuals who found something during their training that they're really interested in and wanted to really become an expert in that particular area. And that was true for me. I certainly enjoyed doing hip and knee replacements. I found that even the complications that would come up, I found very interesting and very satisfying to help treat. And so I knew that it was worth it for me to spend an additional year to really become an expert in this area.
You know, that's interesting you say it that way, that you found out. And by the way, folks, too, so it's not a negative that an orthopedic surgeon decides to not go into a hyper focus into a fellowship. It's actually just for general surgery, you're totally fine and competent. And so, and what he's saying is the fact that this is, you said something here that's really interested me. As you were going through your training, you saw this interest in this one specific category, and that's kind of where you may tail off and focus to. You said that you found an interest and almost an affinity to the fact when there was you said that when, I don't remember how you said it exactly, but the failure or when a revision was needed, you saw, or there.
Oh, I said, yeah, when it came to taking care of the complications associated with it. You know, in some cases, some other areas of orthopedics, when the complications would come up, you kind of, slump your shoulders a little bit and say, okay, here we go. This is going to be tough. But I found when it came to joint replacements and failed joint replacements, I found it exciting. I found it a challenge that I really relished. And that is kind of how I knew I wanted to really focus my practice on this particular area.
So, folks, I'm gonna kind of do a sidestep comment here, and Dr. Roedel is just gonna kind of listen as I say this. So, everybody, I've been in practice for 20 years. I deal a lot across the board. I deal a lot with bone, joint, knee, hip issues. I'm a referral source as far as that goes for lots of this stuff. And what I found is that in certain cases with certain practitioners, if there's a complication, I've noticed some surgeons have the disposition, demeanor, and patience to deal with it, and some just kind of go, I'm done, kind of thing. So, and now I'm going to pull back to our conversation here. Is it because you have just kind of a patience with the process and working the patient through both physically and I'll say even emotionally as well too, if a complication arises, and you're willing to kind of be there for the long haul to sort things out with them?
Yeah, I think that's a good way to explain that. I get a lot of satisfaction about helping to educate patients as I'm taking care of them, make sure that they understand what's going on with their body, what's going on with their hip or knee replacement. I don't really want any part of what I do to be a mystery to them. And so I really view myself as an advocate for my patients as I'm helping take care of them. So I've put in the extra time in my training to really have a solid understanding of how hip and knee replacements function, how they fail, and what the different treatment options are, as well as getting some hands-on experience with some of the techniques to take care of these bad complications. And all of that, I think, empowers me to be able to, lean into these complications rather than feel intimidated or feel like I need to run away from them.
Excellent. And that's going to be exactly how we're going to dovetail into this this whole segment here as well. So what I'd like you to do for all of us, I'd like you to begin with an overview. And like I told you before we started coming on air here, I kind of preloaded this show as well, too. I started talking to patients about it that you're going to be on. And I would tell you out of the woodwork, I just had a guy in this morning. He was like, hey, my neighbor, his hip failed. He had an infection in there. And I go, okay, how'd it go? What happened? So he was starting to tell me a little bit about it. And then, I had to move on to the next patient. Just did an evaluation of a guy on a shoulder situation. And so all of a sudden, as soon as I started bringing this up, people just started talking about it as I brought it up as a purpose for the topic. And I know as it goes, we all hope, and generally speaking, and I kind of say this half jokingly to patients, if I do an exam and imaging, I go, oh, you need a new hip. And they go, really, Dr. Larry? And I'll say, yeah, but I'd rather tell you need a new hip than a back surgery. So because they go so well. And I always say knees are a close second. So generally speaking, these are more rare things that happen. They're complications. But Dr. Roedel is the guy, fellowship trained, that showed an interest in doing this, and he wants to roll up the sleeves. But in order for us to kind of wrap our minds around this, let's just start with the basics and give us an overview of failed joint replacement. What is a failed joint replacement for, let's say, a hip? What does that mean? And maybe describe 2 or 3 causes for each, and then we'll go into the knee as well.
Yeah. So in broad strokes, and this applies for both hips and knees, in broad strokes, a failed joint can be described as one that is painful or dysfunctional, has progressive bone loss or fracture around the components, or has an infection of that joint replacement. So more specifically, the most common causes of failure that we see, and really on both the hip and the knee, are going to be loosening of the components. So the interface between the implant and bone, or between the bone cement that was used to hold those implants in place and the bone, that interface can loosen over time. Infection is either the first or second most common, along with loosening. And then instability of the joint, where it is either dislocating or moves in a way that the patient does not feel like they can trust that joint.
Got it.
Some less common causes could be things like wear of the plastic liner, corrosion of metal implants, or severe stiffness that prevents normal motion.
And as far as kind of bridging them together, what would be the patient presentation that you notice when a patient comes in with a failed hip or knee? What's typical, some of the gait issues you see, some of the mobility issues, and then kind of maybe give us an overview of like the physical exam side of things. And then I want to jump into what you see on diagnostics as well. I want to restate the reasons here, just briefly, for failed hip knee replacements. Number 1, I'm just quoting Dr. Roedel, painful or dysfunctional. Number 2, progressive bone loss or fracture around the components or infection. Specifically, loosening of the components between the implant and bone, or between the bone cement used to hold it. Infection, instability, wear of the plastic liner, and corrosion of implants. I just wanted to restate that for you. Now, here's another comment I'd like to make. Keep in mind, if you have chose to have a hip replacement or a knee replacement and might need of one of these materials, or have prosthetic materials, cements, and fasteners, these are objects, parts that are foreign to your body, but are being inserted in order to replace and reinforce deteriorated and or damaged pre-existing hips or knees, your stuff. Why do I bring this up? It's important to recognize and appreciate and respect these parts are being surgically inserted. They're not your parts, but they become a part of you, and therefore, just like that new car or new roof, your new prosthetic has incredible durability, can withstand the pressures exerted on it, millions of repetitions with angles on it, bends, lifts, etc. Part of your responsibility is taking care for it like you would anything else. And what do I mean by that? Take care of the health of your body. Bones, muscles, ligaments, tendons, both before and after a hip or knee replacement. If you're a healthy individual, both in diet and exercise, congratulations. However, if you know that you can do better, your diet lacks, your exercise habits aren't the best, then you're not giving these prosthetic materials the best environment to exist in and could potentially lead to a failure. So, for example, you heard Dr. Roedel state that progressive bone loss between the interface of the bone and the prosthetic can be caused. Let me drill this down just a little bit further so you can catch my drift. I'll use two hypotheticals, Bob and Tom. Both 60-year-old males who had to have total hip replacements. They received the same implant by the same doctor on the same day. Bob is a go-getter. He follows a balanced diet, likes to exercise, but stays within boundaries of reasonable exercise, moderation, and for the duration of the rest of Bob's life, he enjoys that new hip without any issues. Bob remains strong, his bones, and are healthy because of his lifestyle. Therefore, his prosthetic hip enjoys a good connection and interface for decades. Our hypothetical patient Tom is a total mess. Poor diet, little exercise, sedentary life, both before and after surgery. Tom develops pain in his hip sometimes and especially after surgery and after the evaluation and diagnosis, with what's revealed is bone loss around the hip replacement has become weak and fractures. The cement isn't holding up well. It becomes loose. Tom needs to have a revision. In these two scenarios, I cite one way in which you can either help or hurt the hip prosthetic by decisions you make as well. There are other issues which we will cross in this interview later on and as it progresses, but keep those hypotheticals in mind as well too. So next, patient presentation or prosthetic failure. When we get back from the break, stay tuned. This is the Dr. Larry Radio Show. We'll be right back.
We'll be right back with Dr. Larry. We're back with Dr. Larry.
If you are just tuning in, we are finishing up part one of our topic on failed hip and knee replacements and infections, then the revisions. How to know if you should have this checked out? Let's listen to Dr. Roedel tell us. Roll it. What would be the patient presentation that you notice when a patient comes in with a failed hip or knee? What's typical, some of the gait issues you see, some of the mobility issues, and then kind of maybe give us an overview of like the physical exam side of things, and then I want to jump into what you see on diagnostics as well.
Yeah. So sometimes the presentation is obvious. So someone who comes in with recurrent hip dislocations, or if they have a fall and fractured their femur or fractured their tibia around their implant, those are pretty easy to recognize that something's wrong. But more often, it presents in a little bit more progressive and subtle way. And so typically, the symptoms that people are coming to me with, they may describe groin pain or thigh pain that they notice during activity. They may notice a progressive limp where it's painful for them to put weight for a full step on that affected leg, or they may notice that it's hard for them to maintain their pelvis level when they go to stand on one leg, that it feels like the hip is giving way or is not able to support them. Certainly any redness or drainage from an old surgical incision is very concerning for infection going on. And then I pay attention to other things like, is their pain worse when they first get up and start activity, or is it pain that tends to progress as they move throughout the course of their day? Or is it pain that wakes them up at night and keeps them from being able to sleep? All these different factors I can associate with different reasons for why that hip or knee replacement might be failing. And I use it all together to help it understand a little better.
So we've got history, we've got patient presentation. what do you see on or what type of diagnostic imaging do you use? And then what do you see in diagnostic imaging that may or may not build the case and let you know what's going on?
Yeah. So when I've got someone come into my clinic, I do follow a fairly standard pattern just to make sure that I'm consistent and that I'm not missing anything. So after getting an understanding of their pain and when it bothers them, I'll do a physical exam. So for that, I'm specifically looking at their gait pattern. I'm examining the affected joint to see where sources of pain are. And then I'm looking at range of motion and then several provocative tests that can help me localize where that pain might be coming from. I pretty much will get x-rays on every patient. Some individuals will have x-rays that they come with already. And if they have that, I'll review those first. But I want to make sure that we've got adequate and up-to-date imaging to really know what the hip or knee is looking like at that particular point in time. And I can see evidence on that imaging sometimes of loosening of components, or change in component position compared to previous sets of x-rays. And sometimes we can even see some changes within the soft tissue that clue us in that more imaging might be needed. If based on that initial evaluation, we feel like we need more information, we may order a CT scan or an MRI or even a bone scan, which can provide more information about what's going on with the affected joint.
Okay.
And then in some cases, I'll get lab work as well. So if we have any concern for infection, I usually will screen with a set of blood labs. They're not specific for infection, but they are sensitive, meaning that if I see that those numbers are elevated, I've got a good clue to investigate further for infection.
So as far as the cases that you see, and we're going to get into some successful cases here that you've treated and or have witnessed as well too, dealing on the interpersonal side of the patient and their disposition when they have something like this or appears to be this way before they actually know. What is the typical patient disposition when they're coming in? Obviously, they're bringing you imaging from some other area. What's your approach to that disposition? And I get a sense sometimes too if people that I've encountered that have had failed hip or knees, it's an instant blame, like the doctor did something wrong. And then secondly, and it might be a distant second, there's something wrong with the equipment that's in there. And then the third is, oh, I might have done something I shouldn't have. And I bring that up because there's another surgeon I know, and he does hernia surgery. He's general surgeon. And one of the things he's like, yeah, Dr. Larry, I had to tell patients, please, after I do the mesh, do not overdo it because it's going to pull, tear, and it's going to do things, and it's not the mesh's fault. And so I guess I'd like you to maybe describe the patient disposition, maybe some 1, 2, or 3 factors that you typically have to deal with, and maybe how you deal with those as well too. Or what are you seeing as far as patient disposition goes? Disposition. It's a fancy word I like to use, which means this. Mood. A person's general attitude or mood. Tendency. A person's natural or prevailing tendency of spirits, or leaning toward a particular way of thinking or acting. Quality of character. A quality of character, a habit, a preparation, a state of readiness, or a tendency to act in a specified way. That is the definition of disposition. Just figure I'd give the definition out there because I always like to use it. I think sometimes put it in notes as well too. So I try to read that like a kindergarten teacher. It didn't work out. Okay, next week is going to be part 2 of our interview. We are going to lead off and discuss the disposition of patients and failed hips and knees. It can be an emotional thing. Your disposition plays a role in how you approach this difficult situation if a replacement has failed. Do you automatically blame the surgeon, blame the parts and materials? Do you blame yourself? Try not to preload your attitude into a negative mindset. More so, if you are dealt this hand, approach it with a cooperative mindset regardless of the reason of the failure. So somebody like Dr. Roedel, who specializes in this, can get the best outcome for you. In part 2, he will go over his very methodical process that he goes through to properly diagnose failures and infections right there at OSMS. And if you think you might have this issue right now, no need to wait until next week. Give OSMS a call today at Green Bay, 920-430-8113.